Today we're going to talk about medial branch blocks and some fluoroscopic anatomy of the cervical spine. Well, these are some of the things we need for the procedure. So this is sterile drape for the Mayo and a Mayo stand underneath this. This is sterile drape for the patient, something to clean the patient. This is chlorhexidine plus alcohol, otherwise known as ChloraPrep. This is a 25 gauge, 1.5 inch hypodermic needle. Some people use a spinal needle. It just depends on the approach you're taking and the body habits of the patient. This is some small bore tubing that some people prefer to use to minimize manipulation of the needle. This is a 3 cc syringe. We don't use huge volumes for the C-spine, so this should be enough. And we'll either be using 2% lidocaine or 0.5% bupivacaine in contrast. And this I'll just use as a radiopaque marker to know where I am on the patient using fluoroscopy. Last but not least, sterile gloves. I usually use size 11, but this is 7.5, so I guess it'll do. We're doing our cervical medial branch block from a lateral approach. Often when you do that, you have your patient in a lateral decubitus position, and you'll notice our patient is in a prone position. I can't really put this model in a lateral decubitus, so we'll do it prone and work with what we got. Something I wanted to point out is that the cervical spine is often lower than what I think is intuitive. So we'll peel back this fake skin. Don't have any nightmares, please. Don't show this to your kids. This is C1, otherwise known as Atlas, C2, Axis, 3, 4, 5, 6, 7. And you can see C7 is all the way down here. So I think that's just kind of nice to point out with this really nice model. So I'll put this skin back on. And then we're doing this from a lateral position, so I'll clean the lateral side of the patient right here. So we'd be cleaning right here. And, we've then put on our sterile drape. I'm not going to do that because this is just demonstration here. And then we would take a shot and see where we're at. Let's kick this off. So this is a lateral cervical spine x-ray or radiograph. This is not a diagnostic radiograph. It's just a fluoroscopic image. And its purpose is just to go over some of the relevant anatomy for this procedure. I'm not a radiologist. This is just meant for demonstration purposes. So we'll make a line right here, and this is called the anterior vertebral line. It corresponds to the anterior longitudinal ligament. We'll do the same here for the posterior vertebral line, and it's corresponding to the posterior longitudinal ligament. And we'll do the same for this. This is going to be our spinal laminar line, which corresponds to our ligamentum flavum, and it's the confluence of the laminae onto the spinous process. And then if we outline the tips of the spinous process here, it would be our posterior spinous line. We'll go over some of the relevant anatomy now, and we'll start anteriorly and then move posteriorly. Just real quick, this is the ramus of the mandible, and this is the body of the mandible. Ramus up here too, and then this is the angle. They're not overlapped. But then, so we'll count the cervical spine now. So we'll have C1, so this is the anterior arch, and then you have the anterior tubercle of C1, and then you have the posterior arch of C1, and then you'd have C2 down below. This is the vertebral body, and the vertebral body extends into the dens, which articulates with C1. It goes up here like that. And then you'd have the posterior arch of C2. C3, we have the vertebral body right here, and then C4 and so on. You can't actually see C7 down here, so sorry about that. Between the vertebral bodies, you have the intervertebral disc space. You can't actually see the disc because it is not dense enough and not radiopaque enough. And then posterior to that, I suppose almost sort of at the same level, is the transverse process. So you have the transverse process here, and it has a unique shape because it is bifid, much like the spinous processes, in that it has an anterior and posterior tubercle to the transverse process. Then we would have the pedicle, and you can see a good pedicle down here on, 4, 5, 6. Between this space, you would have the neuroforamen, or the intervertebral foramen, which the nerve root comes out of. And the nerve root comes out, and this would be the ventral ramus, and it kind of goes posterior to the vertebral artery, which the vertebral artery be running all the way up here between the transverse processes, the transverse foramen, or the foramen transversarium. Posterior to that, and I know this is getting crowded and it looks crazy, but you have the lateral mass. And the lateral mass, taken all together, you could call it an articular pillar. So I'm trying to outline them all sort of stacked on one another. And they are basically articulated with one another, and you'd have an inferior articular process and a superior articular process, and those together would then make the zygoapophyseal joint or the facet joint or the Z joint. Behind that is the spinal canal, and that would basically be this diameter, and then behind that would be your spinous process. All right, let's do three-dimensional time now. I guess I suppose as much as you can be on a two-dimensional screen. Shout out to Demo Spine, by the way, for these models. These things are incredible. I really like them. This is cervical spine. It's large and in charge. World of Pain MD. That's awesome. These things you can take apart, and I really enjoy this C1 and C2 for me right there. But we will just use a portion of it because we don't need the whole thing. We'll use C4, C6. So let's go over the anatomy here. We have the vertebral bodies, and obviously they're going to be smaller on a C spine than they would, say, the lumbar spine because they bear less weight. And just at the top here, you have these unsnip processes, and these are present from C3 to C7, and they form the uncovertebral joint or the joint of Luschka. They help in stabilization and flexion extension of the C spine. Lateral to that, you have this transverse process, and you have an anterior and posterior tubercle of the transverse process. And then you have this transverse foramen or the foramen transversarium, if you want to be Harry Potter or Gandalf about it. And they protect and house the vertebral artery, which comes off the subclavian artery all the way up to the brain to form the basilar artery at the bottom of the brain. The vertebral artery enters in at C6 behind this very large anterior tubercle, which is known as Chesenax tubercle or the carotid tubercle. Posterior to that, you have the pedicle. And then posterior to that would be the lateral, or I guess the lateral mass or articular pillar or articular column. It has multiple names, or at least it's referred to by multiple things. The articular column has this inferior and superior articular processes to it, which form the zygoapophyseal joint. And you can see that right there, or the Z joint or the facet joint. So in this, foramen here, you'd have the intervertebral foramen, which the spinal nerve comes out of, or the neural foramen, and that would be the ventral ramus. But just immediately posterior to that, sort of right over the lateral mass, would run the medial branch of the cervical nerve, of the cervical spinal nerve. And that is going to be our target for these cervical medial branches. Posterior to that, you have the lamina, and then you have the spinous processes, then you have the caliber of the vertebral canal or spinal canal. So this is C4 through C6, and the spinous processes are typically bifid in the cervical spine, and that runs from C2 to C6, not at C7 though. So let's get back to it. Okay, the next thing is to talk about our alignment of our anatomical structures. There are four main rules to keep in mind when taking a true lateral radiograph. And you can see here, our first rule is already violated because we want a very clear intervertebral disc space, and it looks like our transverse process is sort of riding up into this. And then, same on this side. This looks pretty okay. This looks relatively okay. So there's that rule, intervertebral disc. Next rule, you want your transverse process to be in the superior posterior upper quadrant of your vertebral body. This one looks like it's riding a little bit high, so maybe this rule has been violated. This one looks pretty okay. Then, so TP. Then you want your articular pillar on both sides, so the right and left side, to be overlapped. And the way you can tell that is you want one radio opaque line that's very dense and crisp. You can see that pretty well for C4, C5. But when we come down to C6, I wouldn't say so. It looks sort of like there's multiple lines and it's not very dense, especially for C3D. You can see multiple lines, not very dense, multiple lines, not very dense. And then, so we will write down for articular pillar, TP, AP, IVD, and then you want your vertebral or your spinal to have at least half the width to be radiolucent. We'll say spinal canal, SC. So we've kind of violated some of these rules, and you can't really do this procedure in violating these rules. The main thing is you want your target to look crisp and clean, and our target in this case is going to be C4. So with that being the case, we are going to talk about where our target is on the C4 articular pillar. So we're targeting the medial branches of the cervical spine. We know that this is C3, for instance, and we know that this is C4. For the C-spine, the nerves that come out correspond to the vertebral level below, which is opposed to the lumbar spine, in which they correspond to the vertebral level above. And that's because you have C1 coming up above here, and then you have all the way to C8 down below, but you can't see that. But there are only 7 cervical vertebrae. So you have the ventral ramus coming out from the intervertebral foramen or the neural foramen, and then immediately there's a medial branch that peels off right here. And this is a little different for the C3 and C7, so I'm not going to talk about these in this video, but the way in which we target these is basically targeting the centroid of the lateral mass of the articular pillar or the articular column. So this X marks the spot right in the middle is where we target for our medial branches. Nice, demospine back in action. Okay, you can see the 2 arrows coming out of the intervertebral foramen, the burnt orange representing the ventral ramus or the spinal nerve, and then the pink representing the medial branch as it courses over the lateral mass. We target this right in the center, exactly where that arrow lands right now. So again, I'm going to draw that right here. X marks the spot. For C5, it runs particularly right dead in the middle. Some of the medial branches, again, this is not going to be ideal because the articular pillars aren't lined up, but some of them run a little bit more cephalad, a little bit higher, depending on where you are. The thing is we would have to reposition the C-arm for each one of the levels. In this case, we could target C3, or we could target C5 here, or we could target C6, but we'd have to reposition the C-arm to optimize our image. So I'll place a radiopaque marker, in this case a needle, over the C4 articular pillar, and then we'll take another shot. All right, if you're very observant, you may have noticed that this is a completely different C-spine. We still have our radiopaque marker right here, but the reason I wanted to leave this in is how poorly these articular pillars are positioned. There's really no overlap here. And so this is really important because you can't distinguish which one's proximal or which one's distal to you as the individualist, and that becomes dangerous. So it's really important that these are overlapped when we perform this procedure as well. So I want to leave that in there as a sort of another example of a cervical spine in a lateral image. So really at this point, you would have to reposition the C-arm and get that true lateral in order to proceed. So we see our target on the X-ray, and we're going to make a skin wheel right over that target. Just 0.5% lidocaine, just a small one. So skin wheel there. And then because of the body habitus of this model, we'll be using, this is a 22 gauge, but you should be using a 25 gauge 3.5-inch needle, okay? So you don't want to cause more pain or irritation to your patient than you need to. So we'll place that right over our target, and then we will take an image to make sure we're right over the area. All right, we're back with our original C-spine image here. And so we have our C4 articular pillar, we have our needle shaft in the hub of the needle. And I just wanted to bring your attention to anterior to these articular pillars, right in this vicinity, we have our spinal nerve and we have the vertebral artery that runs through here. So there's a lot of important structures and you have to be very mindful of that. And then sort of deep or distal to this, behind this, is going to be your spinal canal or vertebral canal with your spinal cord in it. So there's a lot of very important structures here. That's why being very thorough with your imaging before you proceed is really important. We like where we're at on X-ray, so let's keep advancing with intermittent fluoroscopic photos. Okay, we've touched also on a lateral image, but because we're working in 2D, we need at least orthogonal or multiplanar views. We've rotated our fluoroscope or C-arm all the way for an AP image now. So let's take an image and make sure we know where we're at. All right, I think that this is the coolest view ever. you have an open mouth peg view. Essentially, you have this C2 right here with the odontoid process coming, the lateral masses of C1 right here as well. I think that this is just really cool. And then, so we have our needle heading towards the waist of C4 right here. And if you track down, this must be the waist of C5. If you go inwards, you have the uncinate processes coming off of the vertebral body, forming those joints of Luschka or uncovertebral joints, C6. And then for the transverse processes of C7 and T1, C7 should come down like this, and T1 should come up, attaching to the first rib. And that can be helpful when looking at an AP image of the C-spine as well. So we would inject contrast here, and that contrast should sort of fill this little waist-like area too, and it wouldn't be much contrast at all we'd inject. And then lastly, we have the spinous processes you can see through here too. Okay, we like where we're at in the AP image. Now we'd be injecting contrast. I don't have contrast. So let's cheat and see if we're at where we say we're at. So there is C1, C2, C3, and C4. And we should be over the articulate pillar, which it looks like we're over right there on this right side. So that's our contrast, is looking through the skin and peeling back fake skin. Excellent. And then we're ready for our injectate. And just a side note, on the contrast, some people prefer to use this small bore tubing and do the contrast under live fluoroscopy. And you don't need much. You need, maybe 0.25 cc's of contrast. So let's inject our injectate. And in this case, we would inject either, depending on who you're working with, 0.25 cc's or 0.5 cc's of 2% lidocaine or 0.5% bupivacaine. So we take out our stylet, and having a lot of caution not to move the needle, or you could use that tubing, and then attach the luer lock and inject the injectate. It's obviously not the correct volume, but just for demonstration purposes. Anyways, let's take out this needle, and we would repeat the same for C5 and C6. All right, thanks for watching.